Imagine being told that the very exercise you were warned would just completely destroy your pelvic floor might actually be the exact thing required to heal it. But, and this is a big, but only if you know how to breathe.
Yeah, I mean, it's a total paradigm shift. We're so used to treating these symptoms by just, avoiding the activities that trigger them altogether.
Right, which is incredibly frustrating for anyone who, actually wants to stay active. So, welcome to the deep dive. We're pulling from a pretty massive stack of literature for you today.
We've got physiotherapy guidelines, urogyn ecology journals, sports science papers, a lot of ground to cover.
Exactly. And we are zeroing in on one highly specific, but honestly deeply misunderstood question. Does poor breathing technique during exercise actually worsen vaginal laxity and pelvic organ prolapse symptoms?
And, this is an area where the medical guidance has historically been, frankly, pretty muddy.
Yeah, totally.
When dealing with pelvic health, the overlap between just a sensation and an actual structural change creates a lot of confusion for people.
Well, let's clear that up right off the bat because our sources draw a very firm line here for you. Laxity is a sensation, right?
Right, yes.
It's that feeling of looseness or a heavy, dragging feeling. And you can experience severe laxity without a doctor finding any measurable anatomical change at all.
Exactly. Prolapse, on the other hand, is structural. It's an actual measurable descent of the bladder, the bowel, or the uterus down into the vaginal canal.
But whether it's the sensation of laxity or a diagnosed prolapse, the immediate advice people get is almost identical, isn't it?
Oh, absolutely. It's always, stop lifting heavy things, don't squat, limit your intra-abdominal pressure.
Right. And that advice assumes the pressure itself is the villain. But as we dig into these sports science and physiotherapy papers, a totally different narrative emerges.
It really does. It's not necessarily the load on the bar that's causing the problem.
Right. It's the mechanics of how the person is managing the pressure of that load. And that really comes down to breathing.
Okay, let's unpack this. How are the breathing system and the pelvic floor interacting on a mechanical level?
Well, they operate as a closed system. The physical therapy literature frequently refers to the respiratory diaphragm and the pelvic floor as dance partners.
Dance partners!
I love that.
Yeah, it means they are locked in this constant synchronized choreography.
I think the French press coffee maker is like a really great way to visualize this.
Yeah.
If you push down on the plunger at the top, which would be your diaphragm,
Right.
the pressure inside the glass carafe has to go somewhere. It pushes down on the coffee grounds at the bottom. So in our bodies, the pelvic floor is basically the bottom of the French press.
That's a perfect mechanical analogy. It yields to the downward pressure of the diaphragm.
Okay.
When you inhale, your diaphragm descends,
Yeah.
pushing the abdominal organs downward.
To accommodate that shift, the pelvic floor has to drop slightly, lengthen, and stretch.
And then when you exhale, the diaphragm rises, and the pelvic floor just passively recoils and lifts back up to its resting state.
So if the pelvic floor is constantly reacting to the diaphragm, what happens when someone's breathing is dysfunctional? I'm thinking about, the person who is chronically stressed sitting at a desk all day.
Yeah, the classic fast, shallow breaths entirely into the upper chest.
Exactly. The diaphragm isn't moving through its full range of motion. So what happens to the bottom of the French press?
Well, this is where the cascade of dysfunction begins. If you are a chronic chest breather, your diaphragm never fully descends,
Right.
which means it never fully rises either. It just gets stuck in this shallow flutter. And because they are dance partners, the pelvic floor mirrors that restriction.
Oh, wow. So it's just stuck.
Yeah, it never gets a deep stretch. And crucially, it never gets to fully recoil and relax.
Yeah.
It ends up trapped in a state of continuous low-grade tension.
I always used to assume that a tight pelvic floor meant a strong one, but a muscle that's perpetually tense is essentially just exhausted, isn't it?
Exhausted and deprived. We refer to this clinically as a hypertonic pelvic floor.
Hypertonic. Okay.
What's fascinating here is that a strong pelvic floor isn't just about tightness. A muscle's health is heavily dependent on its ability to relax.
Because of blood flow.
Exactly. When a muscle relaxes, fresh blood flow rushes in, delivering oxygen and nutrients and flushing out metabolic waste.
Right. That makes sense.
So if a muscle is held in a hypertonic, rigid state for hours on end due to, shallow stress breathing, it starves itself of that restorative blood flow. Ischemia sets in.
Wow. Ischemia, that makes total sense. If a muscle is rigid and exhausted, it loses its elasticity. It's like a dried out rubber band.
Yes, exactly.
So when you suddenly introduce a massive spike in pressure, say you sneeze or you jump or you pick up a heavy box, that exhausted muscle can't act like a trampoline to absorb the force. It just gives way.
And that sudden yielding under pressure is exactly what exacerbates those symptoms of laxity and prolapse. The tissue gets stretched beyond its functional capacity because the muscle just couldn't support it.
Which brings us to the gym. If the pelvic floor is already struggling to manage the pressure of an everyday sneeze or like a shallow stress breath, what on earth happens when that same person puts a loaded barbell on their back?
Well, the stakes get exponentially higher. In resistance training, we rely on what's called the core canister to manage those forces.
Right, the core canister.
Yes, the diaphragm is the roof, the pelvic floor is the base, and the abdominal wall and spinal erectors form the cylinder. To safely lift a heavy load, all four sides of this canister must co-contract.
So they're bracing together.
Exactly. They brace together to create a rigid, highly pressurized cylinder that transfers the force from your lower body to your upper body without, snapping your spine.
Okay, here's where it gets really interesting, and I'm struggling to reconcile something here.
Okay, what is it?
So, my doctor explicitly told me that holding my breath is the fastest way to worsen a prolapse, and that I should avoid heavy lifting, like deep squats and deadlifts, entirely.
Right. That's very common advice.
But the sports science literature in our stack says something completely different. It says an involuntary breath hold naturally occurs when anyone lifts a load greater than 80% of their one repetition maximum.
It's unavoidable at that weight.
Right. Your body just automatically shuts the airway.
No.
So how are medical guidelines and sports scientists looking at the exact same human body and giving opposite advice? Who is right?
It is a massive clinical paradox.
Yeah.
And honestly, it's a source of huge frustration for patients. To synthesize those two viewpoints, we have to distinguish between chronic strain and acute controlled loading.
Okay.
The medical guidelines are heavily influenced by epidemiological data showing that chronic downward strain absolutely worsens prolapse.
So that would be like working a job where you haul heavy boxes all day or having a chronic smoker's cough.
Right, because it's repetitive, uncontrolled downward pressure. Right. But progressive voluntary resistance training in a gym is a totally different physiological event.
Because it's controlled.
Yes, the sports scientists are correct here. That transient, involuntary breath hold at 80% of your max is a deeply ingrained neurological reflex.
Oh, wow.
Your central nervous system recognizes that it needs maximum stiffness to move the load and protect the spine. So it forcefully closes the glottis to trap the pressure. You cannot safely squat your maximum weight while casually breathing in and out.
So we can't avoid intra-abdominal pressure if we want to lift heavy. And lifting heavy is how we build strength. The core of this deep dive isn't about avoiding pressure then. It's about how we direct it.
That is the pivotal concept. To answer the question of whether poor breathing worsens laxity, we have to look at the mechanics of the breath hold itself.
Right.
And this requires drawing a hard line between two terms that get thrown around interchangeably in clinics, which really does patients a massive disservice.
You mean straining versus the Valsalva maneuver?
Exactly. Straining versus Valsalva.
Let's define straining first, because I think this is what doctors are actually warning against when they say, don't hold your breath.
Yes. Straining is forcefully bearing down.
Yeah.
You are actively pushing pressure toward the pelvic floor, exactly the way you would if you were trying to, empty your bowels on the toilet.
Oh, wow. Okay.
Neurologically, when you strain, your brain sends a signal to relax the levator ani muscles, that's the main pelvic floor group, to let things out, while your abdominal muscles aggressively shove pressure downward.
So if someone is at the bottom of a heavy back squat and they hold their breath and bear down like they're on the toilet to get the weight up,
Right.
that is the exact mechanism that pushes the organs out of the body, stretches the connective tissue, and just drives prolapse symptoms through the roof.
It is a biomechanical disaster for a prolapse. You're taking massive intra-abdominal pressure and aiming it directly at your most vulnerable point while actively commanding those muscles to relax.
Yikes. So what is the alternative?
Contrast that with a proper Valsalva maneuver. Medically speaking, a Valsalva is an attempt to forcefully exhale against a closed airway.
Like when you're trying to pop your ears on an airplane. You pinch your nose, close your mouth, and push air outward.
Exactly.
When I do that to pop my ears, I'm definitely not pushing pressure down into my pelvis. The force feels like it's expanding outward and upward into my head and chest.
And that directional difference changes everything in the gym. When a Valsalva is executed correctly during a heavy lift, it triggers what pelvic floor physical therapists call the vaginal vacuum technique, or VVT.
A vaginal vacuum technique. Okay.
Because you are bracing the canister outward
Yeah.
rather than bearing down, the pressure is contained, and the pelvic floor actually elevates and stiffens to meet the load.
It elevates. Wait, that feels counterintuitive if there's massive pressure in the torso.
It does, but it's a co-contraction.
Mm-hmm.
Instead of relaxing to let something out, the pelvic floor engages alongside the abdominals.
Ah, I see.
It creates a protective vacuum effect, drawing the pelvic organs upward and bracing them securely against the abdominal wall, completely shielding them from being pushed down the vaginal canal.
The analogy that comes to mind is a tube of toothpaste. Oh, that's a good one.
Yeah, if you squeeze the tube from the middle and push all your force downward, which is straining the seam at the bottom, bursts. That's your prolapse getting worse.
Exactly.
But if you keep the cap on tight and you brace the sides equally from all directions, which is a proper Valsalva and an abdominal brace, the entire tube becomes incredibly rigid.
Right.
You could stand a heavy book on top of that toothpaste tube and it wouldn't burst because the pressure is distributed evenly and the bottom is sealed.
That is exactly what we want the core canister to do. We want it to be a rigid pillar of support. This raises an important question, though.
What's that?
How many people in the gym think they are properly bracing their toothpaste tube when neurologically they are actually just blowing out the bottom?
Oh, man. I have to imagine it's a huge number. I mean, we all hold our breath instinctively when doing anything hard, right? Carrying all the groceries in one trip, trying to parallel park in a tight spot.
Exactly.
But are we bracing or are we straining? Well, the research suggests many are straining without even knowing it. There is a fascinating, almost alarming ultrasound study detailed in our sources.
Oh, I remember this one with the 50 pregnant women.
Yes. Researchers took 50 pregnant women and asked them to perform a simple Valsalva maneuver while monitoring their pelvic floors with real-time 3D ultrasound.
And a proper Valsalva should result in the pelvic floor elevating or at least remaining firm, right? No downward descent.
Correct. But almost half of the women involuntarily co-contracted in the wrong direction.
You're kidding?
No. When asked to perform a Valsalva, their brains defaulted to bearing down. They visibly depressed their pelvic floors on the ultrasound monitor.
Did the researchers, correct them?
They tried. They used visual biofeedback. They turned the ultrasound screen toward the women, showed them what their pelvic floor was doing, explained the difference between bracing and bearing down,
Okay.
and they coached them to stop pushing toward the floor. Even with direct, real-time coaching and visual evidence, 11 of those 50 women still could stop bearing down.
That is wild. It highlights a massive neurological blind spot. We just don't have the same proprioceptive awareness of our levator antemuscles as we do, say, our biceps or our quads.
We really don't.
If these women couldn't coordinate a simple breath hold while sitting safely in a doctor's office with an ultrasound tech guiding them, what happens when someone is fatigued, sweating, and trying to deadlift their body weight?
They default to their deepest ingrained motor patterns. For many of us, the most intense pressure management experiences we had early in life were related to going to the bathroom.
Oh, sure.
So the brain wires heavy pressure to bear down. Unwiring that reflex under the load of a barbell requires intense, conscious retraining.
Okay, this is the crux of the issue. If someone listening to this is realizing, oh no, I've been chest breathing at my desk and straining during my squats, how do they fix the choreography?
It takes work.
How do we transition from an exhausted, hypertonic pelvic floor that bears down to one that acts as an elite vaginal vacuum?
You have to start by resetting the resting tone. You can't strengthen a muscle that is already exhausted from being clamped shut all day. The baseline prevention is diaphragmatic breathing.
Which is often referred to as 360-degree breathing, right?
Exactly, 360-degree breathing.
Taking the pressure off the bottom of the French press.
Yes. And you have to be intentional about it. Lying on your back is usually the easiest way to feel it. Place your hands on your lower ribs and your belly.
Okay.
As you inhale, you aren't just pushing your belly out. You are expanding laterally into your ribs and down into your lower back. You are consciously commanding the diaphragm to descend fully.
And then
Then as you exhale slowly, you just let everything passively recoil.
it sounds so basic, but I imagine spending 5 or 10 minutes doing this daily is what finally allows those hypertonic muscles to lengthen and the ischemia to resolve.
It restores the blood flow and resets the nervous system. Once that resting mobility is back, you can start introducing coordination under light demand. This is where physiotherapists introduce the knack.
Oh, I saw this in the literature. The knack. That's the conscious, intentional recruitment of the pelvic floor, right? Squeezing and lifting immediately before and during any activity that spikes your intra-abdominal pressure.
Exactly. It's pre-activating your defense system. Before you cough, before you sneeze, or before you reach into the trunk to grab a heavy grocery bag, you consciously lift the pelvic floor.
So you are literally pulling the organs up and out of the way of the descending pressure wave.
Yes, you are teaching your brain to link upcoming pressure with lift and secure, rather than relax and bear down.
But how does someone safely bridge the gap between, lifting a grocery bag and getting back under a barbell? If an athlete has stopped lifting because squats make them leak or feel heavy, what is day one of their return to lift protocol?
We use a strategy called subthreshold training, and it relies heavily on a breathing technique called exhale on exertion.
Meaning you breathe out during the hardest part of the movement?
Right. Let's use a goblet squat as an example. You inhale on the way down, expanding 360 degrees, as you hit the bottom of the squat and begin to push back up.
Which is the moment of highest exertion and highest pressure.
Exactly. You actively blow the air out, often through pursed lips, to create a little bit of resistance.
Ah. By exhaling, you force the diaphragm to rise, which naturally draws the pelvic floor up with it. It's essentially a safety valve.
A perfect safety valve.
Right, because if the cap is off the toothpaste tube and the air is escaping out the top, you can't build up enough pressure to blow out the bottom.
It is the ultimate safety valve while your nervous system is learning. Use exhale on exertion with lighter weights. It keeps you sub-threshold.
Meaning you are training below the level of load that triggers your prolapse or laxity symptoms.
Correct.
But eventually, if you want to get strong, exhale on exertion becomes a limiting factor, right? We already established you can't lift 80% of your max without the neurological breath hold kicking in.
And that is where the transition happens. As the pelvic floor regains its coordination and strength, the athlete's threshold increases, they can slowly start reintroducing the abdominal brace.
Transitioning back to a proper Valsalva.
Yes, with heavier loads. Because they spent weeks practicing the knack and 360 breathing, their brain no longer defaults to bearing down under pressure.
Right.
It defaults to the vaginal vacuum technique. They can hold their breath, brace hard, and lift heavy, knowing their pelvic floor is elevating and protecting the organs.
So what does this all mean? There is a massive caveat in the sources, though, isn't there?
Yes, there is.
We've talked extensively about breathing mechanics, but the systematic reviews, the gold standard data looking at randomized controlled trials, make a very specific point. Breathing exercises alone are not a magic cure for prolapse.
I am so glad you brought that up,
Not.
because it is a critical distinction. Breathing sets the stage. It resolves the hypertonicity, it restores the blood flow, and it fixes the neurological coordination.
Right.
But coordination alone does not physically hold up a prolapsing organ.
To hold up organs, you need raw muscle mass.
Exactly. The RCTs show that breathing techniques must be combined with actual pelvic floor muscle training, or PFMT.
Like doing Kegels.
We are talking about actively inducing muscle hypertrophy. Just like you would do bicep curls to build arm thickness, you have to do targeted Kegels, often using progressive overload like weighted Kegel cones, to physically thicken the muscle fibers of the levator ani.
You can have perfect choreography, but if the dancers don't have the physical strength to perform the lift, the routine still falls apart. You need the coordination of the breath and the structural hypertrophy of the muscle.
They are non-negotiable partners in rehabilitation.
So bringing it all back to our central mission today for you. Does poor breathing technique during exercise actually worsen vaginal laxity and prolapse symptoms? The literature provides a resounding yes.
Absolutely.
If you're a shallow chest breather, you are starving the pelvic floor of blood flow and turning it into rigid glass. And if you are straining, holding your breath, and actively bearing down like you're trying to empty your bowels during a heavy lift, you are directly forcing your organs down and exacerbating structural damage.
But the empowering reality hidden within that answer is that your breath is also the ultimate tool for rehabilitation.
Yes.
By mastering 360-degree breathing, utilizing exhale on exertion, and retraining your brain to execute a true Valsalva that creates a vaginal vacuum, you transform pressure from a destructive force into a stabilizing one.
If an exercise makes you feel heavy or symptomatic, it doesn't mean you are broken and need to stop forever. It's just your body's check engine light coming on.
Exactly.
It means your current pressure management strategy failed, and you need to drop the load, fix the mechanics, and rebuild.
If we connect this to the bigger picture, what's fascinating here is how much this changes the cultural narrative around pelvic health.
Oh, totally.
Historically, the medical model has framed women's bodies, especially postpartum or postmenopause, through a lens of fragility. The default assumption was that a prolapse is irreversible wear and tear, and the only solution is to wrap yourself in bubble wrap and avoid exertion.
Which brings me to a final thought I want to leave everyone with. We started by talking about how much we like the precision of a broken bone on an X-ray. It's structural failure.
Right.
For decades, we viewed pelvic organ prolapse the exact same way, as a permanent structural collapse that demands a life of extreme caution. But if our core canister actually operates on this beautifully complex, highly adaptable system of pressure management, we've been looking at the problem upside down.
We really have.
What if the ultimate goal of pelvic rehabilitation isn't to avoid pressure at all costs? What if the goal is to train your pelvic floor to become an elite pressure manager itself?